I wanted to officially welcome you all to our offering today, What We Need, which is going to be about building more effective community education materials for HIV cure-related research. Thank you for joining us today. My name is Michael. I am in Seattle, Washington, and I am the Community Engagement Project Manager for Defeat HIV. I also work for the local CFAR Center for AIDS Research, as well as for our local AIDS Clinical Trials Unit, which is a part of the University of Washington. And Danielle, would you please introduce yourself? Danielle?
Sorry about that. I'm here. Can you guys hear me? I'm
Yes,
having a little bit of a challenge with my audio, but I am definitely here. And I wanted to take a moment to welcome everybody into our lovely discussion today.
All right. So, general housekeeping to go through things before we get started. So this meeting is being recorded, and it will appear on the Defeat HIV YouTube page as well as the Facebook page that we run. So there's two ways that you'll be able to access it if you wish to do that afterwards. You're going to be able to unmute and mute yourself. But please, we ask you to remain on mute if you're not speaking, and that'll help cut on the background noise. We also pay attention to the minimum, to the background noise that you might have going on around you, and see if you can't minimize that. We're going to encourage you to please ask your questions. You can use the chat box if you wish to write your questions down or to do that. You may also raise your hand if you look for where it says reactions on your screen. You can use the raise hand feature and we will see that, Danielle or I, and we will then be able to call on you and ask your question. Or if your question is pressing and we don't seem to notice you, you may unmute yourself and just politely interrupt and say, "Excuse me, can I ask a question?" And then when you do that, we will stop and our speakers will stop and you'll be able to ask your question. We prefer that you ask questions in real time because I think that's leads to a more engaging conversation rather than having everybody talk and saving questions till the end. We try to keep the questions more limited to just sort of clarifying type questions in the beginning. If you wanted to get off into a big philosophical discussion, let's save that for the latter half, if we would. And so thank you for that. So, Danielle, would you like to take this slide?
I sure can. So again, thank you all for your attendance in today's webinar. Here's a brief outline of what we're going to do and what we're going to discuss and who you're going to hear from. So really briefly, we'll have some discussion by Lainey Henley and Sam Ndukwe from UNC Chapel Hill. They'll overview some of the demographics, perceived needs, topics and format, language, other things that you see listed there. And then we'll hear from Dr. Chris Roebuck on some of the key recommendations that sum up what we as a community have discussed. You'll see a panel discussion from the illustrious William Carter, Tom Villa, and Dr. Luis Montaner, and then we'll wrap with a Q&A. So you guys are in for a treat.
And so a little bit about what we're talking about today. So we are here to discuss with you something that we decided to do as members of the Martin Delaney Community Advisory Board back in the fall of 2020, and that was to conduct a needs assessment in our community. And this needs assessment was really our attempt to try to create a well-rounded HIV cure research education tool, which is called the CUREiculum, and which was created by people prior to us. Some of us were in that prior group that tried to create the 0.1 and or the 1.0 and the 2.0 versions of these slide decks for educational purposes around cure. We were really looking to increase the literacy around cure among our community members who probably don't have much scientific or clinical training. And our assessment is providing us suggestions on how to build more effective community education materials. So this is the community taking work of the previous community and building upon it. So we're standing upon the shoulders of giants that came before us. And 69% of those people that we talked to basically told us there was some great need for better materials. Currently, they said anything that's related to cure was too technical for most people living with HIV, especially. And so we wanted to share this, that the work in cure is immense. There's so many pieces. And so the need for our materials to be able to reach as many people as possible is also immense need. And this was the needs assessment committee that helped us put this together. And so for this webinar specifically, what you're going to be hearing from us, you're going to be hearing the key results of this needs assessment, the key recommendations, and then we're going to get into a discussion of all these findings that we have to share. All right. And so one last thing that I have for you, and I'll put this in the chat, but you can download this needs assessment that we have. And this is the link, but I will put that in the chat once we get started with our presentation. So if you're interested in having a copy of it, please have it and use it well, in good health. All right, and so we're gonna have first our speakers, Lainey and Sam. If you're both ready, if you wanted to introduce yourselves to us first, and then we'll get started with the presentation.
Of course. Hello, everyone. So grateful to be here with you all today. My name is Lainey Henley, and I am working with Dr. Corinne Dubé's team at UNC Chapel Hill, and looking forward to sharing some results with you all from the needs assessment today. Sam, do you want to introduce yourself?
Yes, thank you, Lainey. Hi, everyone. My name is Sam Ndukwe. I'm also working with Corinne Dubé's team at UNC Chapel Hill, and it's a pleasure to see you all.
Great. So now to begin, we can look at our demographics table from the survey participants. So you can see we had a good number of people respond with 130 participants in the survey. And as you can see, there was also diversity of ages and locations represented. Next. Participants, 83% have heard of HIV cure-related research. However, when we asked about how many people were currently involved in HIV cure-related research, only a quarter of people that we talked to were. Next. This means that almost 3/4 of participants were not involved in HIV cure-related research. And then when we look at the affiliations of those participants, some of the major affiliations were AMFAR Institute and ACTG Clinical Trial Unit CABs. Next. Some of these respondents were people living with HIV, some long-term survivors, HIV health educators, and HIV medical case managers, among many other roles. Next. And then when we ask the question, do you think there's a need for better lay audience information about HIV cure-related research? The vast majority of participants, almost 3/4, said yes, while only 10% said no. Next.
Now, respondents provided a range of reasons as to why there was a need for better lay audience information about HIV cure-related research. One being that HIV cure-related research was very different from, but is often confused for HIV prevention and treatment. Another was that the limited understanding of HIV cure science, where there was many community members that still struggle to understand some of the purposes and goals of this type of research. And some respondents did emphasize the need to debunk myths or some misconceptions and pointed out how increased HIV cure-related research knowledge, it could improve recruiting participants for future clinical trials.
Sam, if we could take a quick question. I see Patricia has her hand up. Patricia?
Yeah, thank you very much. I just wanted to ask a quick question in terms of how did you recruit your participants for the study in your different locations?
We'll get to describing the methods later on in the presentation.
Okay, thank you.
No worries. If you could please lower your hand, and Sam, we'll turn it back over to you. Thank you.
All right, thank you. Thank you for the questions too. Some salient quotes, such as these, were expressed that some of the challenges respondents felt that were barriers to increasing HIV cure-related research, understanding, and helping to improve lay audience communication. One respondent even said that they think that people sometimes think that there is a treatment, which then implies that there is some type of cure. And another said that health literacy regarding HIV cure research issues is needed for better awareness and understanding. Next, please. Several respondents also mentioned they just wanted simpler materials, plain English, about HIV cure related research to facilitate better HIV cure science understanding. The information that's currently available is too technical for most people who even live with HIV to understand and to engage in meaningful conversations surrounding HIV cure science. Respondents share sentiments such as the average person doesn't understand the scientific terms, nor do most understand how to even read their labs. The wording used is often highly techno jargon rich and it's not understandable to the layperson. Another reason in support for better lay audience information was that providing simple information about HIV cure related research would help people living with HIV and their affected communities more effectively engage in the research process. Partly because not being able to understand HIV cure related research, it demotivates individuals from engaging in research studies and then helping to further the field. This results in a loss of valuable perspective, as described by the quote to the right, saying that without the input of people living with HIV, then there will be no output. Next, please. Other respondents also reported a need to clarify information about the possible risks and benefits of HIV cure related research because there is still confusion regarding the potential risks to participants
Hold on.
and the benefits to these studies.
Could everyone please mute?
I think there's a mute all option.
I know there is a mute all option. I'm hoping.
I think it's Christina.
Yeah.
I'm now I'm doing a chat, and then I want to send it.
Okay.
Okay.
I was unmuted.
Okay, Sam. So if you want to unmute yourself and continue, sorry about that.
No worries. Thank you. As I was saying, yep, there's still confusion regarding the potential risks and benefits to participants when they're engaging in some of these studies. And you go to the next slide. The need to reach more diverse populations who are underrepresented in research, it can't be emphasized enough. Respondents expressed the significance of improving lay audience information about HIV cure-related research, particularly for young people, African Americans, and the transgender community. This is particularly important given the prevalence of mistrust in biomedical research in certain populations and the barrier this poses to recruiting participants from minority communities that are also disproportionately affected by HIV. Respondents noted that having basic information about HIV cure-related research would really help them educate others in their community about this form of research. This is a vital step towards increasing transparency and helping to dismantle a lot of those misconceptions that surround HIV cure science right now by communicating up-to-date information, um, up-to-date research information that community members can actually comprehend and help to provide feedback on. Next. Now, an overwhelming number of respondents said that a central website would be extremely useful to receive information. Just one single trusted source, as well as social media, since it's so frequently used. In addition, respondents emphasized the need for educators on social media to help to improve dissemination of HIV cure science information to different audiences, depending on where they are. Finally, respondents explained that we also need to provide education to researchers, particularly around the use of appropriate and non-stigmatizing terminology, because even researchers, those with years and years of experience, are still confused over some things such as the appropriate use of terms like active reservoir. Also, researchers still sometimes use stigmatizing and medically inaccurate terminology.
Really quick, I wanted to give Christine a second to ask her question. Do you still have a question, Christine?
I did have a question. I mean, maybe I'm going ahead of it, but just the word analytical interruption treatment with your art. Just the word analytical. It's a complex word for some people. I mean, we know what that means, but when they sign up for a trial, do they know what that means? That's all I'm wondering. How we can change that word into a word that makes more sense. Because people stay away from things they don't understand.
What would you
That's a
think
good
if you
point.
said it was a monitored treatment interruption?
Yeah, that's a monitored, a very well watched.
Right?
I mean, if you're or at least see if the people have issues first with language, reading. Offer them GED classes. Ask them how high the grade they went in, so that you know what level they're on. Find the level they're on, and then we can we can have a thing for the level that they're on of reading and writing and what they understand. They should take like a basic knowledge test, kind of. So you know. That's all. I mean, it would make it so much simpler if we knew what people knew.
Right.
Thanks for sharing that.
Yeah, thank you so much, Christine. So back to the participant makeup, less than half of participants said they have a basic understanding of HIV cure-related research. About a third said they have a good understanding, but a fifth of respondents said they don't know much. Next. And then when we ask participants about what these modules that would be created should include, so basically what content should be in them, 3/4 of participants considered a basic overview of HIV cure-related research to be extremely important, and 2/3 believed that an overview of possible HIV cure strategies currently being studied would be extremely important to include.
Lainey, could you say that part again? It was garbled for me at least, and I'm worried that it might have been garbled for a lot of other people.
Yeah, of course. So what we're seeing here is when asked about what the modules that are going to be created should include, 3/4 of participants, so that first bar up at the top, considered a basic overview of HIV cure-related research to be extremely important to include.
Okay.
And then this bottom bar, 2/3 believed that an overview of possible HIV cure strategies being studied would be extremely important to include in those modules.
Thanks.
And then when we're drilling down on cure research strategies, more than half of the respondents considered combination approaches, therapeutic vaccines, and broadly neutralizing antibodies, immune-based therapies, and early antiretroviral treatment as extremely important to include in those modules. Next. The aspects of cure-related research that participants considered extremely important were HIV treatment interruption, combination approaches, and measuring the HIV reservoir. But of lesser importance to participants were animal models. Next. And then when asked about the importance of ethical, regulatory, and community considerations, 60% or more of respondents considered informed consent, considerations for participation, ethical considerations, and the role of community and stakeholder engagement as extremely important to include also in these modules. Next.
Based on the responses to the needs assessment, we have generated key themes that we believe should be included in the curriculum training material to address important HIV cure science topics. And these include HIV cure related research approaches, such as methods of cure, dissemination techniques, or research strategies. Also, HIV persistence, which deals with the main barriers to finding a cure. Others were ethics surrounding HIV cure related research, such as therapy strategies, perceptions of people living with HIV, which is a vital theme for capturing the concerns and the values of potential participants, their community, and loved ones, and population specific considerations that will help to amplify the voice of underrepresented minority groups such as Black, Indigenous, and other peoples of color. We also believe themes centered around educating viewers on the methods to properly review HIV cure related clinical research protocols were extremely important, and hype versus research, which deals with managing expectations by providing actual facts and helping to dismantle those misconceptions surrounding HIV cure science, should also be included in future modules. And lastly, some other suggestions included educating audiences on helping to become HIV cure related research advocates, which seemed pretty popular as a theme among respondents, and so was ethics of compensation and the incentives behind research participation.
We wanted to know what way would be best to share this information, so we asked. And the formats of the curriculum that participants preferred, as you can see, were visual aids, videos, and animations. Next. Additionally, participants suggested other formats that generally stemmed around activities that could spark discussion and questions. Examples given by participants were printed materials and open access databases, also quick 2 minutes of reading or video segments, and online modules. Other suggestions were media campaigns, virtual sessions, classes for advocates, and the application of these modules in college and university settings. Next. When asked about the length of how long each training should be, half of the participants said that each component should take between 30 minutes and an hour. A third of participants, though, thought that they should be less than 30 minutes. And these responses are such as the proposed learning objectives of that specific module, the complexity of the material, and the level of understanding of the audience. Next.
Now, drilling down a bit, certain themes also emerged when analyzing some more responses. Respondents indicated that the length of training modules depended on a number of factors, such as learning objectives, the complexity of topics, or the materials that are going to be given to the audience. In other words, for a simpler topic, less time is probably necessary, but for more complex topics, we should warrant more time because we really want the audience to have time to grasp the material. Next. Oh, yeah, that's good. Respondents also reported that the audience's level of understanding of the topic or content provided should be taken into consideration when developing these modules, keeping in mind that respondents preferred visual and dynamic training modules rather than simply staring at a screen, which I think we all are familiar with now, or just listening to mundane lectures. You know, people like to see visuals, see things moving. Lastly, respondents considered the training modality, whether it's videos or images, whatever it may be, and the target audience intended to receive the training as important factors to really consider when we're helping to design the format of the module.
So then back to the numbers, we asked about the language that these modules should be translated into. And a little under half of the participants perceived Spanish to be the most important language for translation, while also American Sign Language and Chinese were other highly ranked languages for module translation. And you can see those other languages that were less than Spanish and the other ones mentioned. And then for other suggested languages, other languages suggested were African languages such as Zulu, Daluo, and Swahili, also Hindi and Arabic, among others. And these languages would be of particular importance in the global research community. Next. When asked where they normally get their information about HIV, the data show the internet was the most popular source of information for our participants. However, other popular ways ranked close behind. Some of these include HIV or other health organizations, community HIV education events, and their HIV care team. Next. But an overwhelming 89% of participants said that they would like to have a central website for this information. Participants said that a centralized and trusted source of curated materials like a website would be most helpful to them in understanding HIV cure-related research. They said that frequently used platforms like social media and the use of visuals and tables would be helpful, and materials created with the community in mind and those with a combination of teaching modalities would be helpful as well. Materials that increase the opportunity for meaningful dialogue and consistent and updated information were also all mentioned. Next.
When asked about possible suggestions to help increase understanding of HIV cure-related research, respondents suggested various strategies, including a user-friendly and reliable resource hub consisting of information that can be easily shared and understood by audiences who may not have the extensive years of research experience. Also, establishing realistic expectations of what audiences should learn about HIV cure science because it could be so technical, and communicating that progress, such as the development of an HIV cure, it would likely take years to actually bring to market and distribute. Respondents also conveyed the need for better two-way communication and networking where researchers and community members educate one another instead of researchers merely disseminating information to the community and not actually receiving feedback from the community. Several respondents strongly suggested more intentional outreach to minority and vulnerable communities that are underrepresented in regard to HIV cure science research. Respondents noted the vital role these communities that are also disproportionately affected by HIV play in the future of HIV cure research. Furthermore, respondents suggested equipping HIV care providers with more material to help increase HIV cure-related research understanding. The hope is that providers can present more available information to their patients and the community whom they care for and may have already established that trust. Respondents also communicated the need for involving previous HIV cure trial participants to improve lay audience communication of HIV cure-related research. One respondent so notably mentioned that we should engage spokespeople who have participated in trials or clinical research and then carefully select for researchers who can help speak to lay audiences effectively. Sometimes they get caught up in the jargon and the high level science, and they don't realize that they've already lost most of the audience, and there's that lack of communication. Regarding the use of social media, respondents recommended reaching out to community leaders who possess the necessary social influence and collaborating with scientists and practitioners who then have the HIV expertise to effectively communicate important information to a wider range of audiences. Respondents also underline the role community members play in challenging misinformation that is so easily spread online, and the importance of having HIV cure science advocates online to provide insight as well. So trying to cover all bases here. Lastly, respondents noted a lack of attention from the general public and advocacy groups and suggested using sustained long-term initiatives to generate and retain greater public understanding and increased support needed for HIV cure research.
To note, some additional thoughts were also shared about how to inform the community about HIV cure research. In regards to reaching the community, a participant noted the importance of informing people living with HIV outside of those involved in CABs. And another thought was to solicit articles in minority-owned media. Next. There were also thoughts surrounding engaging both the community and scientists together in dialogue, because the community has the power to make sure cure research is acceptable in their communities. And also reaching out to practitioners, as one respondent mentioned, they need to be given more opportunities to disseminate their findings in their respective communities. Next. One participant even mentioned finding and mentoring advocates so that they can use popular platforms such as social media outlets to reach the community. Next.
When asked how community-friendly information about HIV cure-related research would be used, many respondents said that they would host workshops to share insight with family and peers, engage the general public at health fairs, and train future potential participants and their families. Other respondents expressed how they would use the information to share with clients or community organization leaders to promote HIV cure research. Several care providers stated that they would share this information with their patients and educate them on the significant role they play in participating in clinical research trials. Self-education was also reported as a use for community-friendly HIV cure research information. Some said that they would read it and consider their own participation in a trial or being more informed about the future. Others said that they had a personal interest and desire to enhance their understanding of HIV cure-related research. Also, several respondents stated that they would use the information to destigmatize HIV. One respondent so notably mentioned, "I would use this information to destigmatize the disease and encourage people living with HIV to participate in more research to help find a cure." This quote seemed to encapsulate respondents' desire to support those suffering from HIV by eliminating the misconceptions that burden people living with HIV and hinder HIV research participation going forward. Lastly, multiple respondents reported that they would use this information about HIV cure research to inform their colleagues, share their insight on social media outlets, and just enrich their personal networks with accurate, up-to-date information. And before I turn this over to Chris for the recommendations, Lainey and I just wanted to thank everyone who contributed to the needs assessment and the report, and all of you for coming to this webinar. And your input is extremely valuable. We love to hear it. It was really a team effort, and now I'd like to hand it off to Chris.
Yes, and thank you, Lainey and Sam, for the presentation. So, Chris, if you wanted to go through our key recommendations.
Fantastic. Well, first, I want to thank Lainey and Sam for this fantastic overview of the needs assessment. It was powerful and illuminating. My name is Chris Roebuck. I'm a medical anthropologist. I'm a member of the research team, and also I'm a member of the Community Advisory Board of Beat HIV, which is located in Philadelphia. So the recommendations we have are really building upon, before I move on, I also want to echo and welcome everyone and appreciate your time and being with us today. So building the needs assessment, the key recommendations that we have are really building upon our experiences, the conversations that we've had, as well as the responses that we received to the study. And we have encapsulated and summarized the responses in order to collate them or filter them down to about 9 doable and actionable recommendations. And we hope that during the Q&A session, as well as in the chat box, that you feel free to add recommendations that perhaps we have forgotten and that you would like to see added as well in our conversations. So the first recommendation that we have before us is that community participants in HIV cure research should be recognized as partners in the research project. I think this makes sense to all of us who have been working in the field of HIV for years. Historically, we know that the best science gets done when impacted and affected communities are working in partnership with researchers and medical providers. As we found repeatedly in the needs assessment responses is that HIV cure-related education and training materials should be communicated in language and formats that are accessible and meaningful, both for people living with HIV, but also for communities disproportionately affected by HIV as well. Also, we adamantly believe and recommend that HIV cure-related efforts, both educational and training, should address and seek to rectify the underrepresentation of women, Black, Indigenous, and transgender individuals and other communities that have been not only underrepresented in HIV research and educational efforts, but in many ways have been historically excluded from the process. Another recommendation that we have is that HIV cure-related efforts, again, in training and education, be very explicit and clear about the risks and benefits of participating in HIV cure clinical research, including not only physical and physiological effects, but also mental and psychosocial effects as well. As we know with HIV cure research currently, there's oftentimes not a direct benefit to the participant. And so that's something that is important to get clarity on as well with your providers. We also think that information should be shared about all aspects of the research project and the research process so that members of the community and affected communities and people living with HIV and advocates and allies can be partners in the research process, as we mentioned earlier. So ranging from study participation to serving on community advisory boards to contributing to community engagement activities as well. Thank you, Michael. Here we talk, there's 6 recommendations about the informed consent process. And it would be very important that the information provided in the informed consent before someone enters into a study is presented in language that is understandable and audience appropriate. And as well as something that Corinne Dubé and others have taught us repeatedly, the informed consent process should not just be a one-time event, but should be an ongoing process throughout clinical study as well. Lainey and Sam described some of the languages that we would like to see the HIV cure research training materials translated into. And also that education and training efforts should emphasize topics that have been identified as respondents as being most meaningful and relevant to the community. And we've listed these in the needs assessment as well. And finally, the last recommendation is really about how do we disseminate and engage community in training and education efforts. And so we, of course, recommend that community forums, workshops, and trainings are developed with significant input from community members as well. And again, please feel free to add your recommendations in the chat box, as well as during our Q&A session to follow. Thank you all.
Thank you, Chris. So we wanted to take a pause right now and give people a chance to ask any of the questions that may have come up during the presentation of all this data before we get into further discussion of it. So I wanted to give people a chance if there's any questions.
And also the chat box is on fire. There's a lot being discussed about the need to center community, to support community, to really have community at the forefront of these engagement activities and leadership development projects. There's also discussion about the need for this type of research to be centered within social justice frameworks, right? That's what needs assessment, that's what surveying community is about. Jan, if you could come off mute and address your point. Patricia also has her hand up. We'll start with you, Patricia. And then Jan, if you have something you wanted to add, please come off mute.
Thank you for giving me the space to ask my question, and thank you so much for all who have presented so far. Really an enormous amount of work. A question I had, because I'm new to the field of cure research, was there a study or any research being done, and what was researchers and scientists and medical providers' knowledge of how much their community members or their patients or their clients knew about HIV cure research?
So could you say your question once again? I wanted to make sure how much information was given to providers or
No, if there is any research out there that has been done to assess how much or what scientists were perceiving that people understood about cure research. Because there's, from your data, there's a clear indication that a lot of things are being lost, but I'm wondering if the scientists really have the same, they may think, oh, 30% of people don't understand and the rest do, or kind of qualitative research done among HIV researchers
right?
as a themselves.
So I know there has been some of that done with some of the Martin Delaney Collaboratory CAB members. As well, I know in Seattle, we specifically did an acceptability study amongst the underserved populations in Seattle around gene therapy. Did they know what gene therapy is? Have they ever heard of gene therapy? And we went all the way through to gene therapy as a cure and got all of those reactions, just their gut reactions. And then after they thought about it a while. And so there is some done. I don't know if there's a lot that is accessed by providers. I don't know how important they feel it is for them to know where people are.
Well, yeah, you raised something really important, is that when you say you don't know how it is important for them to know where people are, but if we really want to have an equal conversation, I think it would be a fantastic place to start, to be all really aware where people are and care, and really care about where people are at. Thank you so much.
Oh, yes, and thank you for that. And I totally agree with you there that it is important for them to know these things. They need to know where they are. It'll help make the conversation just be that much brighter, and that much more meaningful.
Indeed. We have another question from Christine. Christine, and then Patricia, if you could please put your hand down, that'd be great. Christine.
I unmute. I'm unmuted, but I can't be seen. I don't know why. Anyway, my question is actually, like, when you were explaining how they would need to understand everything, like before I took Project Teach or became a peer educator, I didn't even know about the untransmittable, like, at least know the level of what they even know about HIV, period. Like, do they even know what their T cell count means, or viral load, or, or where it's hiding, like in our thymus, like where it all starts and how, because some people just do things because they see money. Maybe it's, oh, well, I'll get paid to do this. But are they really doing it for the right reason? I'm just saying, to understand it, they would have to know about the virus. And if you don't know your viral load, like, that's a big key in a trial, that you're going to be going off your medicine, and, you could possibly become detectable. So do they know about U equals U, things like that? Those are the things I would want to make sure that they definitely knew that before they even entered the trial.
I agree with you, Christine. I really think that what we're talking about is relationships that are sustained over time. People that all at once, but that's something about being involved with people throughout the course of time, so you actually can understand things like you or even hear about it, because how long does it take for that to get out to everybody? Did anyone else want to comment?
I do.
Go ahead, William.
Well, yeah, we had a. Go ahead.
I think when a person is first diagnosed, I think it's important that we give that person a week or two to think, because I know for myself, when I was first diagnosed, it took me 2 years to really accept that diagnosis. So a period of time needs to go by. And I think we really need to educate the provider and actually have some services in that office particularly, so they can be able to start to train the community with a peer educator, as we call them here in Philadelphia, or with people who know about the virus, who has been living, or a buddy, whatever you want to call it. By doing that, that starts the questions rolling, and how they can begin to hear the different abbreviations and the different lingo that goes on. But it's up to the how I can't stress enough. It's up to the community to go back and teach 10, as Philadelphia Fight said. You have to go back and you have to pull them up to your speed or up to their speed. But it has to start there so they learn how to teach the providers how to treat them, how to educate them, and how it still falls back on us community members to go into other organizations, attend their meetings, and raise questions and do an impromptu teaching session so community members will know on how to educate them and the importance of it. But if we don't start at the beginning, you're just going straight, you're skipping the middle and you're skipping the end, because there's thousands of questions you have, but you're scared to even ask yourself those questions. But if community members teach them how to do that, and how their pen and paper is their best friend, write your questions down, because if you're scared to ask them, you could pass it over to your physician. But we have to start at the beginning, which is with ourselves. I firmly believe that.
Thank you, William.
Yes. Danielle, did you say there was another question?
I thought I saw another hand, but the chat again is on fire.
Yes.
Good night. Well, let me double check to see if there's
Luis
another
has
hand.
his hand up.
Okay.
Luis
Yes.
has his hand up.
Luis, go ahead.
Yes, thank you. I think a lot of really important comments have been made today, and I want to congratulate the curriculum team and the needs assessment. I think that this type of effort is really critical for the research community to come together in one, point of intersection of education and awareness of how we need to be communicating better, educating better, and also listening at the same time. So I know that but I do want to maybe address one point that was raised in the chat about the awareness of the researchers when it comes to community input and needs, because I think that as everything, there's been a lot of continued progress down this line. And I think that the Martin Delaney collaboratories were one really visible investment in making a bridge between the community and the research effort. And I think everyone's really delighted that NIH has renewed this commitment again, giving the entire, education opportunity another 5 years of further growth. And I think that there's already been impact on how the community is represented in the next cycle of this particular effort. And I think that the impact is going to be very visible. So I think having a needs assessment, identifying how best to direct the priority of effort is really going to be very critical at this moment, because as this whole effort gets renewed, there's going to be a lot of discussions about how best to make a difference. So I think there's going to be a lot of groups, including our own in Philadelphia, if we're fortunate to renew, which we expect we will, that we want to listen and take the best approach forward in building communication. And the other thing I would say is that, a lot of groups have made attempts in this. I mean, Beat HIV, as you know, created a position paper on how to engage in a cure trial, how to engage the consent process. It was a product of the community for the community. It also created videos, and these were attempts to communicate. And they're all available from our website. I think Beth just posted the website.
Mm-hmm.
And this was, a 50-some page document together with multiple videos that were put out to see whether that would be effective. So I think we need to learn from the curriculum, learn from these to see, is this the right direction? You know, do we want to continue this type of engagement, or do we need a different type? Like what Lyndon put in the chat, I thought was really cool about, we put a lot of education at the consent, but then we kind of like let go, and they could be on a study for a year and we don't go back and educate them along the way. So how do we do that, you know, without necessarily being perceived as being, you know, influential to somebody staying on a trial? Because you also want to leave people some, you know, space to decide how the trial is going. So, but you know, for that type of articulating how do we do that, I think the community would be really critical, because we need to hear from the participants and people that are aware of what that is like. What would be the best way to do that, and still give the individual some privacy and some, you know, space, that we're not kind of like completely bombarding this individual with a lot of information. So I think there's a lot of room for this dialogue to continue.
I agree with you. And since we've already had two of our panel members speak, Luis and William, why don't we get Tom to chime in? And I saw, William, you wanted to say something more, but let's give Tom a chance to speak. Tom, are you there?
I am. Thank you.
If you wanted to chime in, go ahead.
Sure. First of all, just a brief introduction. My name is Tom Villa. I'm a member of the Community Advisory Board for the Martin Delaney Collaboratory for HIV Cure Research, and have had the privilege over the past number of years to work with the Believe Collaboratory based at Weill Cornell Medical Center, and going forward with the Hope Collaboratory based at the Gladstone Institutes of Virology in San Francisco. In terms of, do you have a particular question or topic, or just responding to what's in the chat? Because
I was saying, wherever you want to take it. I haven't asked any of my questions yet, so I just thought if you wanted to add on to what either what Louis said or what's going on in the chat.
I think there's a lot of discussion that's been going on in the chat about community engagement. I agree very much with Luis that over the years that NIH and the Martin Delaney Collaboratories have made great strides to incorporate community into the research process. Obviously, there's lots more work to be done. And I agree with many of the recommendations and suggestions that have been made here, both verbally and in the chat, about new ways or enhanced opportunities for us to include community in the entire research process as a real partner. And I think that's really important, and would be great for us to continue to work together to do.
Thank you. William, did you have something else you wanted to say? I saw your hand was raised.
Yes, it's just one more thing. I am in full agreement with Lyndon and Louise, but I think if some of the collaboratories, and I'm putting it on the entire Martin Delaney Collaboratory, and let me tell you, well, I am the chairman of the Beat HIV Martin Delaney Collaboratory, and I have been for quite a few months now. But if we, as community leaders, which everyone who is a part of a CAB, if we would be allowed to come into some of the places that we collaborate with, have some of the members go in and become staples there, maybe not a permanent fixture, but a weekly, pick a day out of the week where we are able to come into the clinics, where, you know, maybe a sign or something can be posted saying that questions answered or questions asked, ask me a question. As you see on the Amway people, you know, ask me about Amway, ask me about HIV, or just go, or be able to allow to go into the facility and just walk around in the waiting rooms there, if they would be in agreement. And that's one way, and that would make us approachable, one. And then if they needed someone on one time, they may even ask when they get to the back, they may ask their physician, well, why are they here? You know, and that could lead to a conversation and in training people. But be where our community, we should be allowed to be where our community is at. And then it would be like Delaney said, we would be able to, I'm sorry, not Delaney, Linda said that we would be able to pick up that ball that we have dropped on that consent form, is educating them then, because they are scared. I know I was. So why not have us there to ease the pain?
That's a great point.
Yeah, because I live with HIV. I live with it. I'm not surviving. I live with it. Actually, I allow it to live with me
Come on
because
now.
I'm fine. I'm fine. I'm not sick. I'm not sickly. Was I at one time? Yes, I was. I was where you're at. So don't be afraid to ask me. As everyone knows, the only silly question is the one you don't ask.
Thanks for that, William. I think these are great points that you're making here, right? Anything that we can do as a global community to strengthen those partnerships within communities who are not readily represented in research, we need to entertain, we need to bolster, we need to support, we need to discuss at great length. So seeing your face and making this process very, very real and approachable is something that, it's great. And again, I thank you for your courage to continue to share your story. You make this what we've been saying this whole time. So I wanted to check in. Christine, did you have your hand up again, or did we forget to lower it the first time? Do you have another question?
Hold on. Yes, I did have a question.
All right, come on in, Christine. What's your question?
Okay. My question be, I'm also a person living with HIV. I am on the CAB, and I am the co-chair to William. And most people that I know of that are consistent, go to their doctors, most of them have a case manager, which can explain a lot of things for them. Because, for instance, when you do an analytical trial, you have to go through, paperwork and consent forms. And how many people, when they're, buying something and they say, before you sign the dotted line, there's all these things that, this can happen. That how many people really read that? I mean, or do they just put accept, like on my phone or my thing, an ad will show up and I just, it'll give you all this information and then you have to accept. Not many people do that. They don't read everything that they're signing. So I would just hope that when they are given the questionnaires and things, that if they have a case manager or someone similar to what William offered was a question and answer person, that they don't just sign it without knowing what they have read. That's my thing, because signing it not knowing, oh well, this could make me have AIDS because it will lower my viral load and my T cells. Little things like that. If they don't read it all the way, they're not going to know that. And then when it happens, oh, why did this happen? So my point B is maybe somebody should definitely make sure the consent form is simplified enough that they know exactly what they're signing and getting themselves into. That's all.
Thank you for that. We have a question, or we have a hand up from Mason.
Yeah, I just have a couple things. Yeah, I just have a couple things that I would like to mention. I'm on the CAB board at Harborview Hospital Medicine Clinic in Seattle. I don't always feel like I have much to add. There's a lot of information here that I would not know because I'm not in the research field, and this is far more information than I expected to get out of here. The things that come to mind on a very simple basis. Somebody mentioned have community members or have community leaders start talking about it. I think that that's a reasonable request if they were to be simply asked, hey, can you do more talking about AIDS research, please? We would appreciate it. Another one would be, you should just pay. I'm sure there's plenty of money in AIDS research. There's never enough, but there's some for social outreach. Why not just pay celebrities on Instagram to talk about it? I mean, I don't know. It just seems too simple. The other thing is, let's see, where was it? As a patient for studies, I know I've learned to read the study all the way to the last page, because the last page is where it'll say you get a spinal tap at the finish, or, in the 3 months through it. And I learned that, and I'll still do studies because it's, I found it very easy to develop an altruistic attitude after I became diagnosed. And I think most people who have HIV are interested in finding a cure and will volunteer for studies if approached correctly. So thank you for your time. Thank all of you for being here, and particularly the people who spread out so much information as a buffet. So
Definitely thank
take
you
care.
for taking the time to join and for your
Thank you for
comments here.
sharing.
Thank you.
So I wanted to ask, and I'm going to open this up to everybody, so our panelists, but any of the attendees here listening, we just saw all this information, as Mason pointed out, a lot of it. What stuck out to you? What stuck out to you, whether because it was maybe unexpected or surprising, or maybe it stuck out to you because it's not surprising and you've been saying it for years? But what piece of information, big or small, hit you? I would love to hear that. But let's start with our
Great
panelists.
question.
So could I start with, let's start with Luis.
I mean, I think that what hit me is the potential to do much better than what we've done. You know, I think that, you know, at least on the beat, we're very happy with, you know, the things that we've been able to accomplish. But I think what hit me in this webinar more was that there's still a lot more that we can do, and we can improve how we go about it as well. So so I thought that was inspiring. So that was good.
Thank you for
Thank
that.
you.
How about William?
For me, I'm going to chime in on Louise. One of the things that here in Philadelphia that the beat is doing, one of our investigators is leading, we have started a CAB leadership group where all the leaders of different CABs are invited to come together. We meet monthly. Sometimes we meet bi-monthly, but most of the time it's monthly. And we go over everything from how to increase our memberships together, how to get our names out, how that we should encourage the other CAB leaders to visit one another CABs to get fresh ideas and not look at it as you're stealing idea, but how to enhance. And during this COVID age, take advantage of the Zoom. I know we're all zoomed out, but by using Zoom, you're able to invite people from across the country without a great big budget. You know, if you want to do something monetarily, you're able to, but just being able and that opens doors at other places. You know, it makes room for future blessings for each and every one of us to do. And remember, as I told a good friend of mine today, I went to the top. I'm a positive person, and I took the first positive disease that was available, and it just happened to be HIV positive. That's what I am. I'm a positive person, and I went right to the top. So, and I'm going to stay there and keep engaging each other.
Indeed. And we thank you for that. We definitely thank you for that.
So Tom, how about you next?
Can I just take a minute, Tom, before you chime in? I wanted to thank you for your advocacy and support of this webinar today. You are quite the phenomenal recruiter, and I just wanted to make sure you got your roses. Tom took it upon himself to assist us without being asked in spreading the word about this very critical conversation today. So, Tom, my sincerest thanks to you for those efforts, and please weigh in.
Thanks, Danielle. You're making me blush.
Well, good.
I wanted to add that I think in response to many of the comments and discussions here today, I see a really big opportunity, and in some ways it's a challenge, but I'd like to focus on the positive side. I'm an optimist. I see a big opportunity for us to find or create, as we need to, opportunities and methods to really engage with community members, especially in communities that don't have a Martin Delaney Collaboratory with an excellent, engaged community advisory board and a community partner like Beat HIV in Philadelphia or Defeat HIV in Seattle, et cetera. There are many communities that don't have that. There are many communities that don't have a CFAR, a Center for AIDS Research. So I think it's just really something that sticks in my mind from today is that we really have an opportunity and an obligation to continue to think about ways to engage more people in more places in meaningful ways. So that's what I'm taking away from this.
That's great, Tom. Thank you.
Yeah, I want to just add on to that because I think it's really important that there's been a lot of knowledge acquired over this last 5 years, and there's a lot of mentorship that could be very beneficial at this point when new teams are coming together and trying to figure how best to engage their communities. And I think that this group could be really consequential in gaining a lot of ground by helping to make sure that everyone starts efficiently and quickly, because a lot has already been learned about how best, at least to start.
Mm-hmm. And Michael, if I can just comment there, following on that, on Luis's message, also that we can include individuals like Jeffrey, who's been very active in our chat today, Jeffrey from Kenya, and people in other places where perhaps distance doesn't allow in-person collaboration, but there's no reason why we can't find ways to work together. So thank you. That thinking inclusively and expansively, I think is really important as we move forward.
I like that. And I don't know if everyone has seen what Jessica Salzwedel put in the comments in the chat, but I was wondering, Jessica, if you could unmute and could you explain what a community of practice is?
Yeah, I can do one better. I can even go on video for you, Michael.
Ooh.
A community of practice is just a shared place to share for people who are doing sort of the same thing in stakeholder engagement. Practitioners share resources, strategies, ask questions from one another. And I know that the community of the new MDCs have community partners, and just building off of what was said earlier, it seems like what's going on in Beat with the CABs is a really good practice to mimic, and it sounded like a community of practice. So I kind of put that term on it, but I think it's that meeting of minds that's already happening.
Yeah, no, I agree with you. I like the idea of it, because it gives it a little bit of purpose. Not that it's like a heavy-handed thing, but when you're doing this stuff, this is what you're doing. You're actually acting like a community of practice. You're all together doing something and practicing it as you're doing it. Like the doing of it, the coming together is the practice as well. So I just wanted to make sure everyone heard that term and got a little idea, but I think it's a great idea as well. Seems like other people felt that as well. Did anyone else want to respond to my question about something that either surprised you or just confirmed something that you believed? Oh, Pauline, I didn't see your hand. Sorry, please.
Hi, everybody. Thank you so much. It's a real honor to be here and to listen to people speak. I'm humbled to be part of the Hope Collaboratory, and I'm from Lakehead University, beaming in from Thunder Bay, Canada. My background is as a Canada Research Chair in Arts Integrated Studies, and that means that I use the arts in data collection as a way to analyze work and also disseminate research. The part that stood out to me in the recommendations was number one, the idea of the community or participants as partners. And I think that a lot of the discussion that happened was about how do we bridge that space. And as I was listening, I was thinking, I really liked what Christine said about the case manager. Because in my work, my background is in education, so I'm a teacher, and I'm always conscious about how we teach. And this great story that I always come back to is, you could be an excellent teacher because you know how to teach a dog to whistle. But if the dog can't whistle, it doesn't matter how good you are. So the curriculum could be fantastic, but if there isn't a capacity or the literacy of the group that you're teaching, if they don't have the capacity to whistle, then it doesn't matter how good it is. So as I was thinking about this, I was thinking about how a lot of our discussion is using the concept or a model of bridge. You know, here we have a community and here we have scientists. And I think that Lori also said in the chat, you know, the scientists are not thinking about community. The community people aren't really thinking about the, you know, what's in the test tube. They're really thinking about their space. And what we need then is the third. And if we think about or conceptualize here and a sort of a path in between, we don't have the environment or the space for learning that is possible. And so creating the mediated space or the third point would, I think just conceptually, if we can imagine sort of a third point, then you've got an area where growth can occur, or the not yet can grow, as opposed to a bridge where everything can only flow in either, you know, back or forth. So I think how we conceptualize or dream up the concept for how the environment or the space of learning can occur is an important part for moving forward. And that conceptualization then offers a space for birthing the unknown. So no answers, but just thinking about how we are imagining the possibilities.
Yes, I think that's always important, taking the time to create the space in order to manifest something new. You have to create that space intentionally. It doesn't just happen by accident.
Indeed. It's not accidental about the work we do.
Did anyone else want to take a stab at that question, share a little bit of that? So then the other question I promised the panelists that I wanted to ask, because it was been asked to me many times, and it was mostly coming from providers, healthcare providers, and they were just asking me, like, why was this topic for this webinar important? Why would anyone want to know this stuff? And you know, sometimes it got my rankles going, but I wanted to ask the three panelists if they wanted to give us their answers to those people who wrote me those emails of why any of this should be paid attention to.
I would love to answer that.
Go ahead, William.
I would ask them, why wouldn't they want to know?
Exactly.
And that is the question. Now I'm questioning you. Why wouldn't you want me to know? Without me, you don't have a practice. I don't care how smart you are, how many degrees you have, how much staff you have. But if I pick it outside your clinic, you won't have any of that. So I think you need to engage the community, speak with us, help educate us, bring us up to the level so you can speak with us and not at us. Take out all of your cartoons and all your jokes and truly get to know your clientele, get to know not just your clientele, but the community that you serve, because the more you know, as the commercial says, the more you grow. So it's our job to stop having, I'm going to call it a silly question because that's the way I personally feel. I'm not speaking for the beat, I'm speaking for William Carter. If you ask a silly question, I'm going to give it to you back. But that's something that you should ask yourself. Why wouldn't I want to talk to somebody who I can engage in a full conversation? Because if I'm able to ask you a question like this topic, why wouldn't it be important? How are you going to help me stay healthy? Because if I feel as though if my physician or as me being a part of a study, my researchers stop dreaming, guess what? My dreams are dead. I wouldn't be, a month and a half, close to 2 months without taking any medicines. I never would have thought that, and feel like I'm in my 30s and I'm close to 60. So we want to know better. To know better is to do better. And if our physicians are able to talk with us, not at us. And remember, guess what? You own the practice, but you work for me. So I am ahead of my team. You're not, I'm allowing you to be in that position because there are other physicians who do care, who do live with the same virus as I do, and who are thriving and not surviving. So that question should go back to them. Why wouldn't they want to speak to a fellow educated person?
Thank you for that.
Mm,
Thomas, I see your hand.
thanks.
And then we have
And
Pauline.
then I think Pauline.
Yeah, good.
Thank you, Michael. I would, in answer to this, I would really have to say that I have never had any of the scientists or researchers involved in cure research ask me that question.
Mm.
The response that I get is that from the scientists, from the scientific teams, is that all of them are interested in knowing more about our perspectives, our views as community members, our experience of living with HIV, and love hearing the impact that their research has on us.
Mm-hmm.
I think the real challenge is, obviously, many of them are busy. And to the extent that many of the researchers working on cure research may not necessarily be clinicians, so they're not treating HIV patients every day in a clinic.
Right.
They may not have the day-to-day interaction
Mm-hmm.
with a lot of people living with HIV like a clinician would.
Mm-hmm.
So that's a challenge, but they're looking to make the connections and to learn with and from us as well. So I think it's a mutual challenge, a mutual opportunity for us to find or create that third space, that third point,
Mm-hmm.
as Pauline mentioned earlier.
Mm-hmm.
That I think is the opportunity.
I agree with you. And just to be clear, these emails were going out globally. So I don't want y'all to think that the Seattle researchers specific were giving me this pushback. And I also have to wonder sometimes the pushback was coming as a little bit of a, like they were just trying to tease me to get me going. Sometimes I have to wonder if it wasn't just like they were asking those things. But nonetheless, it was truly asked of me. Pauline, let's hear what you wanted to say.
I just wanted to add that the third point isn't the space where I'm imagining that the growth happens. That the third point is sort of a boundary or a point, so that within there's this triangle of space that is much larger than one space or one circle that's part of the event. I actually did want to respond to some other points along the way that I think that I've always had the assumption, and I've heard it in this session as well, that there is an assumption that everybody will want to be cured. Why not? Mm-hmm. And I recently spoke to someone, and he's approaching 60, and he said he's been living with HIV for most of his life, and his body has adapted and become stronger, and he would not be interested in messing things up now. Mm-hmm. And he is perfectly happy. His life is in control. He controls his life every day. And it just made me think, because he said he spoke to his partner and said, "Would you do it?" And he said, "Of course not. Why wouldn't anybody want to be cured?" But this person that I was speaking to talked about, the identity of being HIV positive, and your identity is, what you have. If that is your core identity and you lose it, what do you have then? And I think that is something that we need to consider as we move forward. There's probably a large population of people who don't want to be cured because of identity concerns, discussions around that.
I agree with you. In fact, we were lucky when we did our reunion project in Seattle. We had 2 breakout sessions around cure, and we had Timothy Brown there. And it was a room full of ideas, and leave it to our long-term survivors of HIV to have lots of different wisdoms that we may not have conceived of. And some of them were even more practical. Some of them were worried about the benefits that they have right now. If they no longer have HIV, are they still disabled, or are they still going to get certain help? Or are they going to all of a sudden, after years of being able to live one way, told at the end of their lives they have to all of a sudden figure out something else. So it brought up all these different questions that were really beyond, the identity was a big part that came up. And there were a lot of people that expressed to Timothy that they weren't excited about being cured and that they didn't have an interest in that. Besides the fact that we don't even know yet if any of the cures will be a total classic cure, an eradicating cure, or if it'll be something less like more like a remission where it'll eventually come back. Some people might not want to go through that hassle, knowing that antiretroviral therapy is great and will keep them suppressed. They don't have to worry about any sort of undetectable viral load being lost. So there's lots of reasons I think that people might not want to be cured. And I've heard a lot of them. I was privileged to hear that.
Michael,
I want to
can
just
I
stop
just...
in.
Sure, go ahead.
Yeah. Okay. Jeff made an amazing point in the chat. Jeff, if you can come off mute
go
and
ahead.
talk about that.
Sure. So,
there we go.
Focus. Can you hear me now?
Mm-hmm.
Yes, we can. Thanks.
So many people, especially the long-term survivors that Michael was just talking about, 30, 40 years of living with HIV, they didn't have effective treatments for 10 or 15 years. They've experienced a lot of damage that they're living with now. This is chronic damage, the long-term survivor syndrome, the premature aging we hear about. And a cure is not going to reverse that. It'll get rid of the HIV, but it's not going to reverse that damage. So I think we really need to be aware that we're going to have a subset of people who are going to have compromised health, even if we manage to cure everybody, and the real concern is there'll be this forgotten community because people say, hooray, we cured the disease, we'll move on. And you'll have this subset of people, just like with long COVID, right? You're going to have people who are going to have sequelae that will have the rest of their lives.
I think that's a great point. And I'm glad you were able to take yourself off mute, give it. It's a great point. Like, we can't undo the years of damage that HIV has wreaked on some people's lives. So it's important that we're upfront and honest about what that means to some communities of people. But I do see Beth has her hand up. Oh, I'm sorry. Go ahead, Will. And then Beth.
I was looking in the chat room and I think her name is, I want to be correct. I think her name is Alicia. I understand where some people may come from, where they say they may not want to be cured. I get that, but we always want to make sure that they are still participating and feel safe having that discussion. Some people may ask me, would I want my right leg back? I would have to tell you no, because I went through a whole lot. I'm healthy, I ride a bike, I do anything that I want to do. I set my own limits. And people living and thriving with HIV, I get that. They still should have the right to choose if that is good for them and their lives. And they shouldn't be ostracized. They should be welcomed and embraced like we are being here. So you may not understand it, but that is perfect for their life. It may not be for you, but you should respect their decision not to want to have the cure for them. And that's where I stand with that.
I have a question. Could I talk? Yeah.
Christine, go ahead and ask yours, and then we'll hear from the person who's been waiting.
Can you, okay. You can hear me?
Yep.
Okay.
Yes, we can.
Okay, my question is, it's similar to what Will said. I'm a longer term survivor. I would have to say it would be the cure, would the people on board with it would probably be the younger generation, the ones that just got it. But also, this was supposed to be about people taking PrEP too, so that they can stop spreading it or not get it if someone or a partner of theirs has it. So the whole point of the PrEP, so, okay, you don't want to be cured, but yet you're going to risk still giving it to other people. You have to look at it from a point of, we still have laws about how giving it to someone, it's a crime. Criminalization comes involved in that. So, if there's a cure, I get that maybe that is their identity, but I identify, I didn't even want to admit it. Like, some people don't even realize or think they have it or care for years. And still, even when they say it, they still don't accept it. My thought is, what if there's a cure today, it will not reverse my necrosis. It will not reverse any of the damage, because I've had it where the medicines were like 20 pills a day. You know, there's like even what Will said about his leg. Would I change that? No. I had to go through all that to get where I'm at today with HIV, the knowledge I know. There's a famous person, that says people perish for the lack of knowledge, to know it. So if you catch someone young and there's a cure, I would hope to say, hey, look, get this cure now and don't go no further with it, because the medicine does do things to you. Your body works 24/7 overtime to rebuild your immune system, and it works way much more than anyone else's. They got to realize that we age faster inside. We don't look at outside, but inside we are a lot older than we appear. So I would
thank you for that.
Yeah.
Thank you. And such great questions you posed today to the group, Christine. But I did want to defer to Michael. Michael, you had your hand up so patiently. Please come off mute.
Yes, and just to point out, we're almost at time. So I think, Michael, you're going to be our last question for today. Pressure.
You'd think after 18 months of dealing with this, I'd be more adept at unmuting myself. But I put this point in the chat, which is that not only can we not reverse the damage physically that many long-term survivors have suffered, but the damage to our careers and our ability to support ourselves and to explain a 20 whatever year gap in our employment history, and therefore the inability to get employment that would replace SSI or SSD, and the employment that carries the insurance that would cover some of the damages that, even if HIV were out of the equation here in the USA, you know, that's how you get insurance and healthcare coverage. You know, I have managed to find a job in HIV care as a peer treatment educator after 25 years on disability, but my original career path is long gone. I don't have the PhD that I would have had I not had 3 rounds of PCP 30 years ago.
Amen.
And that has to be taken into consideration in addition to that physical damage that will never go away.
I hear you. I hear you there. And I think there's even other things, just the toll it takes on people, you know, the emotional toll, the mental toll, as well as the physical tolls and the spiritual tolls, we could say. There's so many things that we need to heal. One of my friends here in Seattle, who is native, likes to say that we are still working on that biological cure, but we need to be working on these other parts of our psyche to cure, the emotional, the mental, and the spiritual, so we can be ready for the physical cure of HIV to come, and really make sure that it gets to everyone everywhere on this earth. So thank you for sharing that, Michael.
Indeed.
I appreciate that.
Indeed.
Danielle, I think we've reached the end of our 90 minutes.
We have, and again, thank you to the illustrious group of folks that have come together. Sam Laney did a tremendous lift in pulling together the needs assessment. Kareem, thank you. All of the other folks on the Curriculum 2.0 work group. We meet monthly. Chris Roebuck, Michael Luella, our great beautifier, William Carter, Lori Sela, Tom Villa, other folks who I may not, Jeff Taylor. Thank you. Thank you. Today is a manifestation of almost 1 year of work that we've done to really bring together the voices of community to show the scientific, researchers and infrastructures that control billion-dollar budgets around HIV, that here's what we want to see from you all as it relates to HIV cure-related research. So we should continue to control that agenda. So thank you all for your time. Michael, any closing remarks?
I just wanted to remind everyone that I will be putting this recording onto a YouTube page as well as to the Facebook page. And some people have been asking for the chat. I will make sure that I send that out with an email with the links to the videos recorded once they're posted. So it might take me a day to get it together, but just give me that day and I'll get you all of that, chat included. Okay? So thank you all very much for coming. I appreciate each and every one of you being here and participating in the ways that you did. Much appreciated. Thank you very much, and have a beautiful rest of your summer.